unmute. And hello, welcome to the Native Chart webinar series on hypertension. My name is Cindy Gamble. I'm Tlingit and a tribal liaison at Partnerships for Native Health at Washington State University. We are so glad that you joined us today. Here's our agenda. First, we'd like to tell you a little bit about us and the Native Chart Project. Then, Dr. Charles Magruder will present on provider-patient partnerships, working together for better blood pressure outcomes in communities. We will have a 10-minute question and answer session at the conclusion of Dr. Magruder's talk. We want to share with you that although Zoom has the raise your hand feature, we are asking that you please hold your questions until the end or type your questions into the chat box, and Dr. Magruder will answer your questions in the question and answer period. Also, within 24 hours of this webinar, we will be sending you a link for an evaluation survey. We hope that you will help us to learn from this experience by participating in our survey. All participants will be entered into a drawing to win a $30 Tango gift card. We are Partnerships for Native Health, or P4NH, and we are housed in the Initiative for Research and Education to Advance Community Health, or IREACH, at Washington State University. Partnerships for Native Health was formed due to an interest in American Indian Alaska Native health and research and the clear need for information and data on the health status and social determinants of health that contribute to the challenges faced by our populations. Our model of partnering with tribes and tribal communities on projects of interest and importance to them has proven to be successful. We have now expanded our model of conducting community-focused research to other populations who are experiencing health disparities and or are not involved in the needed research to help address the disparities. IREACH conducts research with American Indian, Alaska Native, Native Hawaiian, Pacific Islander, and Latino populations, populations with substance use disorders or addictions, and rural health networks. Our IREACH faculty belong to various colleges at Washington State University, and faculty at the different colleges are partners on projects with IREACH. We conduct community-based research and education to improve health and reduce health disparities. We do this by working with both community and academic partners in community settings. We support community capacity building by focusing on community strengths and interests. We started out with a focus on American Indian and Alaska Natives that has now expanded to include other indigenous and rural populations. We work with both tribal and urban populations and all ages across the lifespan. We have over 160 partners, which includes tribes and urban Indian health programs, tribal colleges, universities, and now Native Hawaiian and Pacific Islander health and community organizations. Our center works on issues and topics that are important to the populations that we serve. Examples of some of these important issues are alcohol dependence, substance abuse prevention, suicide prevention, diabetes, stroke risk reduction, cognitive impairment and Alzheimer's disease, and of course, high blood pressure. The Native Controlling Hypertension and Risk through Technology, or Native Chart as we like to call it, aims to improve blood pressure control and cardiovascular disease risk factors for American Indian, Alaska Native, Native Hawaiian, and Pacific Islanders with diagnosed high blood pressure. Native Chart has 3 intervention projects and 4 supporting cores, which are the Administrative Core, the Dissemination Core, the Methodology Core, and the Consortium Core. Within the Consortium Core, there are 7 satellite centers, which you see here, which work to expand the network of community partners by hosting annual conferences or symposiums and conducting annual assessments at the local level. And now here are the 3 projects. First, the Chickasaw Healthy Eating Environments Research Study, or CHEERS, focuses on healthy eating and exercise practices which are tribally developed and implemented. The Blood Pressure Improving Control Among Alaska Native People, or BPI-CAN study, will support their customer owner participants to know their blood pressure numbers through providing home monitoring equipment and encouraging heart-healthy life choices, including communicating with their healthcare providers. Engaging Native Hawaiians and Pacific Islanders and activating communities to take steps, or NACs, also emphasizes heart-healthy choices of traditional Native Hawaiian and Pacific Islander food and activities. There is additional support for food purchase and tracking physical activity. And now it is my pleasure to introduce Dr. Charles Magruder. Dr. Magruder is currently the Chief Medical Officer for the California Office of the Indian Health Service. He aims to apply the public health lessons he learned in his travels to ensure access to high-quality care and prevention programs, especially for children. He believes that community and organizational partnerships are essential to reaching these goals. His presentation will examine such a partnership with the American Heart Association. And now, Dr. Magruder.
Thank you very much. That was a wonderful presentation. I'm really happy to see all of those wonderful programs in place. Thank you. As was mentioned, I'm working for the California Area Office of the Indian Health Service. And my focus primarily in this arena is from a public health perspective. But we will have a few items that will come up from a medical perspective as well. And I'll do my best to answer any questions you have in that arena as well. Next slide, please. As you might suspect, there is a lot of data about the importance of blood pressure and monitoring blood pressure and ensuring that blood pressure is not high among patients that you have. And in some of the statistics that you see in this slide, 103 million adults, nearly half in the United States, have high blood pressure. And of course, as you well know, high blood pressure is a contributing factor to a number of major health conditions, including heart attack, heart failure, stroke, and kidney failure, and also a number of other health concerns. But the research also shows that 45.9% of those who have been documented to have high blood pressure are not controlled. And that's about 36.7 million people. So basically what that means is we have a lot more work to do. Next slide, please. You can see here some of the populations from the Pacific Northwest, Alaska Native, Native American, Native Hawaiian, and Pacific Islander populations. And we're looking at 5 states: Washington, California, Hawaii, Alaska, and Oregon. You'll note that the population sizes in these states vary. from about 40 to 50,000 to 300,000. And you'll note that each of these areas have a population that is not native to that area. And that brings into context a number of cultural perspectives, perhaps. For example, having been here in California for about 4 years now, I did not actually have an awareness that we have 116,016 Native Hawaiian and Pacific Islanders, and I'm not aware of any specific healthcare programs that we have for that population. And that's something that after learning about this process, we may definitely need to look into. Next slide, please. In here, you'll note in Alaska, and I'll just focus in here on the heart disease mortality data. You can see that among Native Americans and Alaska Natives, 225 individuals per 100,000 population have experienced heart disease mortality. If you go down and see the Native Hawaiian Pacific Islander who are living in the Alaska area, you see that that is a much lower number. I think that might be an area that merits exploration to examine why there is that difference. Are there some cultural factors here? Are there different demographics of people who do end up moving, say, from Hawaii to Alaska? But that's a very important statistic that I think merits further exploration. Next slide. And in California, again, where I'm from, what we see here with heart disease mortality are actually some pretty low rates, both in the Native American Alaska Native population as well as the Native Hawaiian and Pacific Islander. That is something that we would want to look into as well in terms of why those numbers might be so different from the other states. Next slide. And Hawaii in and of itself, and I know there are some Native Americans who are living in Hawaii, but a very small amount. So the only data that we have here is for the Native Hawaiians and Pacific Islanders, which shows itself to be higher in this geographic area than it is in the United States. Another interesting set of data that merits exploration. Next slide. And in Oregon, you see that there is a pretty high rate among the Native Americans and Alaskan Natives. But again, for the Native Hawaiians and Pacific Islanders who are living there, it is much lower. That again merits some further assessment, in my opinion, because to find out what the secret is in getting that low rate. Next slide. And then finally, we have the state of Washington, where the heart disease mortality among Native Americans and Alaska Natives is actually much higher than that of the Native Hawaiians and Pacific Islanders, in contrast to those two populations being similar in the state of California, for example. Something more to assess. Next slide. So that brings us to what is referred to as the MAP framework. And next slide. And the first question is, who can participate in this process? And basically all medical organizations, from hospitals to health service organizations to small medical practices to a group of practitioners, working in different areas, everyone can participate in this process who is involved in providing healthcare. Next slide. And basically how the program works is you would decide to register to be a part of this process at your clinic or in your private practice or whatever the case might be. And then the American Heart Association staff would begin to work with you to help you customize a plan using the MAP framework, which we'll provide in more detail here in a moment. And then, of course, another key part of that process is ensuring that we're able to measure the improvement as a result of using this particular type of program and report those results. And then the final piece is to reach that point of having 70% or higher of your population with hypertension being controlled. And then that's where the American Heart Association provides recognition. Next slide. So what exactly is the MAP framework where all of those things are getting done? Well, it basically involves 3 distinct processes. The first is measuring blood pressure accurately every time. That's one of the things that has plagued medicine for some time, is we haven't had, and for the most part, a very nice established standard operating procedure for how we would record a blood pressure to ensure accuracy each and every time. And in the upcoming slide, you'll see some of the information about what is done to ensure that that accuracy is increased significantly. And of course, just finding the correct blood pressure for each individual is just the start. We also want to act rapidly to address those high blood pressure readings. That, and again, is another area that has been found to be somewhat lacking when many individuals who are tested and found to have high blood pressure do not immediately have the ability to get treatment. So you want to make certain that you ensure that that process is enabled as well. And that involves some change in how clinic operations will function. And then finally, I think the coolest part of this process that really excites me is the fact that you're actually going to have a process whereby you continue to have a close relationship with the patient, hopefully with their family, and in general, have a great rapport with the community that you're working, so that everybody can work together as a team to promote self-management and monitor progress, just to make absolutely certain that we're providing the exact type of care that's going to be the best for that particular patient. Next slide. Okay, so as we start the process, there are some basic principles that are recommended in this system. Ask your patient to avoid caffeine, exercise, and smoking for at least 30 minutes before the blood pressure is taken. Empty the bladder, obvious reasons for that. And then make certain that your patient is relaxed as possible and has the proper position in the chair with the feet on the floor, the back supported for greater than 5 minutes. And do not take the blood pressure readings while your patient is sitting or lying on an examining table for absolute certain. Make certain that they're in that relaxed state and that everything that needs support is supported. And that all you have to do is go to your patient, they're sitting there in a very relaxed way. You make certain that you place the cuff in the right place, and then we go from there. Next slide, please. And you do want to use one of several validated, calibrated measurement devices. The American Heart Association can give you a lot of information about what they recommend in that arena. You want to be sure the patient's arm is supported on a surface at the correct height, as alluded to earlier. Place the cuff on the patient's upper arm. and make certain that you use the correct cuff size. Sometimes we'll have people come in who might be very muscular and so forth, and we want to make certain that at least 80% of the bladder goes around the arm. And then you use either the stethoscope diaphragm or the bell for your blood pressure readings. Next slide. So what do you assess when you're asking providers? Here are 5 recommended items. Have they used a validated automated upper arm device to measure the blood pressure? Again, a blood pressure cuff is not a blood pressure cuff. You want to make certain that you're actually using ones that have been deemed to work the best, to be the most effective. Obtain the average of 2 office blood pressure measurements, more than 3 if unattended. Should the blood pressure measurements be at 130/80, you want to look at the use of an out-of-office blood pressure measurement to confirm the diagnosis of hypertension. You want to take the time to train patients for the out-of-office measurement technique. And you also want to consider whether or not it might be appropriate to do out-of-office blood pressure measurements. When the office blood pressure measurements are 120 to 129 and in 80 diastolic, if you suspect masked hypertension. Next slide. So at the first visit then, you would take readings from both arms, take subsequent readings from the arm that gave the higher reading, separate the repeated measurements by 1 to 2 minutes. If you use the auscultation method, they prefer a palpated estimate of radial pulse obliteration pressure to estimate the SBP, and you inflate the cuff 20 to 30 millimeters above this level to determine the blood pressure. I know this is kind of getting into the weeds a little bit, but these are all things that over time would become second nature as you begin to learn these processes in the clinical environment. And then finally, if you use the auscultation method, deflating the cuff pressure 2 millimeters of mercury per second, and listen for the Korotkov sounds. That's another key part of the process. Next slide. You record both systolic and diastolic blood pressure. If you use the oscillatory technique, record these as onset of the first Korotkov sound and disappearance of all Korotkov sounds, respectively, using the nearest even number. You note how much time has passed between blood pressure medication having been taken in time of measurement. That's particularly important, of course, with people who may have been already in treatment. Use an average based on greater than 2 readings obtained on more than 2 occasions to estimate your patient's blood pressure, and then give patients both their SBP and their diastolic blood pressure readings verbally and in writing. And that final sentence there is very important. You want to make certain that the patient has a clear understanding of what you have done and what the result means for them. Next slide. So in this case, what do you assess? And asking about the providers. Have they initiated a non-pharmacologic therapy to treat elevated blood pressure? If the office blood pressure is 130 to 39 or diastolic 80 to 89 and patient does not have any other clinical concerns and has greater than a 10% 10-year risk, do you consider out-of-office blood pressure medicine to take home to be able to fully confirm that diagnosis? Now, if the average office BP is 130 to 39 or 80 to 89 diastolic, which is confirmed, and the patient does not have, again, any other chronic diseases, then with a 10% 10-year risk, do you initiate pharmacotherapy? Yes, so you make certain that that's the case. If average BP is 130 to 139, 80 to 89, which is confirmed with SMBP or ABPM, and the patient does not have, again, any of those other clinical activities like diabetes, um, do you follow up every 4 weeks using the treatment algorithm to guide therapy until blood pressure is controlled? If average office BP is confirmed to be 140 over 90, do you initiate or continue non-pharmacological therapy and treatment algorithm to guide therapy using 2 medications from 2 different classes? That's real critical, and that's, again, the reason for this assessment is, again, to make certain that providers fully comprehend what needs to be done for the patient based upon their presentation, including the blood pressure reading, to make certain that you're providing the standard quality of care that has now been established with these new rules. It seems a bit complicated, perhaps, but as you would integrate this into your healthcare system, into the standard operating procedures for your clinic, and as you have individuals trained to help out with each of these different pieces, it's amazing at how quickly you can get to the point that this is just an automatic process for you that you don't even have to think about. I know, again, it seems a little difficult now, but it does get much better. Next slide. So, in a summary then, when the average office blood pressure is 120 to 29 and less than 80, 2 or more office visits, you start non-pharmacological therapy, follow up in 3 to 6 months, and then you consider the out-of-office blood pressure measurement, as was previously discussed. Next slide. And again, just in case your patient has a stage 1 hypertension, that when you see that from an average blood pressure 130 to 139 or 80 to 89, and you find that the patient does not have any of those other possible associated chronic diseases, then they want you to utilize the risk estimator and use a specific treatment algorithm to guide therapy until the blood pressure reaches 130 over 80. And another item that's looked at, the 10-year risk, if it's in a low-risk patient, start or continue non-pharmacological therapy, follow up in 3 to 6 months. Consider again the out-of-office BP measurement to get that additional data. When the average BP is 130 to 139, 80 to 89 millimeters, the patient has one of those other chronic diseases like diabetes, then it's recommended that you start or continue non-pharmacological therapy and treat it as if the 10-year risk is greater than 10%. Again, I understand that this seems a little bit complicated, but once you get the framework and you have the staff educated and they know each step, it becomes very easy. When starting a diuretic, you want to follow up in 2 weeks to check electrolytes and renal function. Next slide. Now, stage 2 hypertension, this is BP 140 or greater than 90 millimeters diastolic. Start or continue non-pharmacological therapy. Start pharmacotherapy prescribing 2 different classes of antihypertension agents in most patients. Now, there is an exception here to be cautious if the patient is elderly. And then follow up every 4 weeks until the blood pressure is actually controlled. Consider out-of-office blood pressure measurement using the 24-hour system for ABPM or SMBP. Reassess on an ongoing basis using SMBP to identify white coat hypertension. That's important. Sometimes you don't think about this, but even when I go to the doctor and I'm thinking, hey, I'm getting a checkup. I haven't had a checkup for a while. What's going on here? you can have some anxiety about what's going on, and you want to take that into account, at least for some patients that you can easily identify, and make certain that you are actually getting that correct diagnosis. And then if you're starting a diuretic, you'll want to make certain that they follow up in 2 weeks to check electrolytes and renal function. Next slide. So uncontrolled high blood pressure needs immediate action. That's the key point. It accounts for more deaths from cardiovascular disease than any other modifiable risk factor. It's second only to cigarette smoking as a preventable cause of death in the United States, and is present in more than half of people who die from coronary heart disease and stroke. There's also a concept that's in place called therapeutic inertia, failing to start or intensify treatment when blood pressure is high. For some reason, it's been a common problem, and that's one of the reasons why people want to establish these frameworks that spell out exactly what is the optimal quality of care based upon the research at this time. Because this is also a leading factor contributing to suboptimal blood pressure control, along with failure of patients to schedule or return appointments, can leave your patient with very serious unmanaged risk, and can be addressed with an evidence-based treatment protocol. And that last phrase there is a very important one, evidence-based treatment protocol. The studies that have been done are the reason for how they have come to the conclusion that all of these other items that this is the standard operating procedure that we need to use, and so we provide the best quality of care and the best options for the patient to be able to get well quickly and to have a much nicer life once those potentially dangerous issues are controlled. Next slide. So in this situation, we're going to talk about partnering now. And this is, again, as I mentioned earlier, is the process that it has me excited the most, particularly with the population that we work with. It's so important to have a great relationship with the patients and the community to be able to provide optimal care. So we want to make certain that our providers are engaging patients using the evidence-based collaborative communication strategies such as TeachBack, encourage patients to self-manage using the self-measured blood pressure, direct patients and family to resources that support medication adherence, promote adoption of healthy habits, and connect patients with resources that can help. And again, foster specific lifestyle changes that can prevent and manage high blood pressure. Now, some of you as providers may be saying, wow, I mean, we've already looking at a whole series of complex items that we're going to be doing in the office. And now we have all of these different things that entail interaction with the community, following up more routinely with the patients, et cetera. And what that kind of boils down to really is looking at your staffing and examining what is it you need to add if you want to be able to say that we are on the cutting edge of how to treat hypertension. We're doing the best we can using the highest quality work and getting all the different parts of the community as well as all of our medical staff working on these things. And they're going to be doing that as a team. It doesn't happen overnight. It can be very hard to do, but it's so rewarding once you get that accomplished. So please don't let that deter you. Take these things step by step, bite at a time, if you will, and you'll get there before you know it. Next slide, please. So the reasons, and I've alluded to this already, I'll go through this quickly, why we want to have that strong partnership with our patients, even outside of the clinic setting, is because some of these factors. The prevalence of high blood pressure can rise dramatically with increasing age. We partner with our patients to help remove obstacles to treatment adherence and make certain that we do all those things we just discussed to get their blood pressure under control. And we can save and extend lives. That is, as hard as it might seem, it's important to do that. Focus on their overall health, including their diet, sodium intake, physical activity, alcohol consumption, smoking, outlining ways they can reduce their risk of cardiovascular disease. And create a blame-free environment where patients are recognized for achieving the treatment goals, no matter how small. You know, as long as you're taking steps that are improving, that's what you got to do, and then you keep getting encouraged, and then you keep going to the next step. And encourage people to ask questions and be honest as in an important step to tackling the problem of treatment non-adherence. And that, to be able to discover that, to be able to have a conversation about that, really requires a very good relationship with the patient. Next slide. So, empower patients to control BP. We're going to guide patients and families to resources. We're going to help support recommended lifestyle changes, and we're going to improve adherence to the treatment plan. Sometimes that requires a lot of patience. Sometimes there's a lot of frustration, but keep developing those relationships, and you'll find it gets easier and easier. Encourage patients to self-manage. Engage your patients in collaborative approach to care using evidence-based communication skills, teach-back method, again, which we've already discussed. Have patients repeat the information back to make certain they understand, et cetera, et cetera. Again, a whole series of things here that we do to make certain that the patient has a full understanding, and we continue to develop those relationships. Next slide. So once the blood pressure is controlled, patients with a diagnosis of hypertension can use SMBP to monitor their blood pressure. They need clear instructions about what to do if they get a reading outside the expected range. Local partnerships can also help some patients, particularly those with lower incomes, achieve their treatment goals. Following through on lifestyle recommendations is going to be challenging, but and particularly with patients with poor social support, but that's extremely important in order to ensure long-term advances in health. And anything that you can do to simplify medication regimens, either by less frequent dosing or by single pill combination drug therapy, also based in the research improves adherence. Next slide. So resources to help, and I won't go into these, but just to make you aware of it. Sodium and your blood pressure. There's a lot of different things you can use to help patients understand why too much salt can cause them problems. And also, again, with help to cook tasty food using less salt. And steps to improve blood pressure, we talked about that, and the importance of lifestyle modifications in getting that accomplished. Next slide. So, treating a patient's blood pressure. Here's a series of things, and again, indicating the difficulty of getting this done, but also, I hope, the importance of working hard to get it done. Stopping, if your patient is smoking, at the same time you're treating blood pressure, you need to try to get them into a program to help them with smoking. Make certain that other chronic diseases like diabetes or hypercholesterolemia, of course, you're going to be doing those tests as well, but keep track of those too. And for patients who are carrying a lot of extra weight, who are not eating a healthy diet, who are not exercising, utilize other staff to help them understand the importance of these things and how that's going to improve their health. And then minimizing all of these risk factors is going to overall help the patients reduce their cardiovascular disease risk. It's hard work, it's difficult, but we got to figure out how we use our clinic staff to get these things done. Next slide. So, MAP, putting it all together. These three components that the American Heart Association has put together do not exist in isolation. Measuring accurately is critical to getting the correct diagnosis and knowing the type of treatment and control that's needed based upon the blood pressure reading. But again, the thing that excites me the most and what I think is most important, partnering with patients on lifestyle changes. That's absolutely essential for them to continue to be able to maintain their health. Next slide. So, other resources to help treat your patients with high blood pressure quickly, as we discussed, using the latest clinical evidence on how to do that. Collaborate with your patients to control BP, including 5 communication skills that may improve engagement. We didn't discuss that in detail, but we certainly look at that information and get it to you if you desire. And patients have questions but aren't sure to how to ask. In that, I didn't discuss too much with you either, but figuring out other methods of communication to make sure that patients have full understanding of what's going on and what's needed is absolutely critical. And you do have a lot of resources to help you with that, and also your staff. Next slide. So, so the AHA is partnered to launch Target in 2015 to improve blood pressure control, build a healthier nation, the national initiative to reduce the number of Americans who have heart attacks and strokes by urging these changes in medical practices. And again, I know that is not an easy thing to do, but it's definitely something that you want to try. Health in patients to prioritize blood pressure control. The Target BP supports physicians and care teams, offering access to the latest research, tools, resources. The American Heart Association can get all of those things to you. So working together, medical practice, health service organizations, we can significantly improve the nation's current national blood pressure control rate of 54%. Target BP is a great process that's given to us to be able to reach these important goals. Please consider it. Next slide. And just a reminder of the fact that fairly recently, the changes were made in terms of how we define when an individual has hypertension. It's much more conservative now. So you can, at a systolic blood pressure of 130 over to 139, or a diastolic blood pressure of 80 to 89, you now are classified as a stage 1 hypertension, whereas in the past, that wasn't considered elevated. And then stage 2, over 140 or greater than 90, definitely you have to move forward with a treatment regimen in most situations. Next slide. And just to make you aware that there are some case studies that have started using these techniques. One of them is from here in California, Chapaday Indian Health, a fantastic clinic, very advanced, work very carefully and spend a lot of time with American Indian clients. And they, in a relatively short period of time, took their blood pressure control rate from 58% in August 2007 to 72% in January of 2018, getting to that first level of recognition from the American Heart Association. And another clinic I'm not personally familiar with is Ravenswood Health Clinic, also in California, and they have done a very good job of getting their program in place as well. Next slide. All right, and thank you for your time. I greatly appreciate. I know that everyone out there is extremely busy, and we really appreciate you taking the time to take a look at new and see how they might work for you in your clinic.
Well, thank you so much, Dr. Magruder. That was a great presentation. Had a lot of great information. And now would like to open it up for questions. Everyone is unmuted at this time. Or wait, I guess we're unmuting you at this time. And I think we're also looking for some, see if there's any questions in the chat box for Dr. Magruder. Okay, so there's no questions in the chat box. Well, there is one question. Let's see.
Well, it is from Janine Dunkel.
Yes.
Is that the correct?
Yes.
Well, I can only speak for the California area office. I believe that the clinic that I just described to you very briefly, Chappaday, would be more than happy to share the information that led them to fairly quickly get to a higher level of performance. So if anybody would like to have that information, if you can send me your communication, your email, or and I will then get that information from Chappaday and distribute it to each of you. I'll also try to call the other clinic in California that I don't know about and see what they can offer as well.
Allow them to talk.
Okay. If that's permitted,
They're not all unmuted. If they want to ask a question, they can raise their hand.
Okay, I'm just getting some instructions here that if you have a question, please raise your hand and then we will unmute you. And as far as the question, as progress is made on our 3 projects, they will be the outcomes and updates will be posted on our native chart website, which is nchart.wsu.edu, and we will be happy to share that. I will pass on your question about the patient engagement tools to the projects, and we can get that to you also privately. Someone asked for this particular slide to be put back up, so there you are. Does anyone else want to be unmuted? Do we have any questions for Dr. Magruder or myself? Okay, well, if we don't have any questions, remember that you can always email us or contact us, and we'll be happy to answer the questions that way. Again, I want to thank all of you for joining us today, and I do want to tell you that our next webinar in our Native Chart webinar series will be the effects of racism on hypertension in Native Hawaiians. This webinar will be on Monday, October 1st at noon Pacific Daylight Time. And our presenter will be Dr. Joseph Kiave Kaholokua, who is the professor and chair of Native Hawaiian Health at the John A. Burns School of Medicine at University of Hawaii at Manoa. We hope that you will join us then. And also, I'm very interested, or our team here is very interested in knowing what topics around hypertension and cardiovascular disease are you interested in and would you like to learn more about? What are some hot topics? If you would please email me here at cynthia.gamble@wsu.edu, we will see about getting more information to you. Okay, well, here is a question for you, Dr. Magruder. One is, did the Chappa Indian change because using the correct blood pressure measuring technique found less people truly having high blood pressure?
Well, do you mean to say using the incorrect blood pressure measuring technique?
Yes, what did they learn how to use the correct, and so that changed? Did that influence it at all?
Okay, I don't know what their motivation was. I think I was with them when the American Heart Association gave their presentation, and Chappa Day in almost every arena wants to move forward to improve based upon current research that is noted. So they very quickly adopted the recommendations or indicated that they wanted to have a trial of adopting the recommendations that were made by the American Heart Association. And quite simply, you know, and I don't say this mildly, their philosophy, their perspective is we want to keep up with the latest information because we want our patients to have the best possible care. That's what motivates them on everything that they do. This is just probably one item of many that they have adopted in order to provide the highest quality care to their patients.
Okay, thank you, Dr. Magruder. And again, I want folks to know our website, nchart.wsu.edu, and we will have different items there about our projects and also about the symposiums that the 7 satellite centers had, so you'll be able to see what sort of information and strategies that they used in their communities also. I also would like to remind you again that we will be sending out our evaluation survey link to you, and we do hope that you will participate and assist us. This is our very first of, we hope, many webinars on hypertension and cardiovascular disease. We plan to have 3 or 4 a year, and we would just love to have you along with us and we can learn together. And also, this entire session has been recorded and will also be available on our website, nchart.wsu.edu, and will be available for you to review again. So thank you so much. We really appreciate your time and your attention, and we hope to see you next time. Have a great afternoon. And thank you, Dr. Magruder.
Oh, thank you so much. I appreciate it.
All right. Bye-bye.